Jag heter Margareta Haag och jag är ordförande för Svenska Ödemförbundet som på engelska heter Swedish Association of Lymphedema. Vi är jätteglada för att vi har fått besök av professor Neil Piller från Australien som är en av världens ledande experter på lymfödem. Och vi har några frågor som vi tänker ställa till Neil på engelska och kanske berör han läget ute i världen och jämför med det svenska som vi då kan här. Och min första fråga då gäller någonting som heter the chronic care model. In Sweden, the chronic care model is not used for lymphedema. The principle of the CCM is active patient participation. Is this model used in many countries for lymphedema? Do you know that?
Certainly in some countries it's used, and while the evidence is not strong, it suggests that the outcomes are better when the patient has involvement in chronic, non-life-threatening diseases and disorders like lymphedema. And it's very important, I guess, with the chronic care model that we try and empower the patient to do things for themselves that they're instructed to do or can do, and thereby ensuring that the patient is contributing to their well-being, their health care and their health outcomes. And we see that it's very, very important. And when I say we, I mean we as the International Lymphedema Framework as well believe that the whole chronic care package, the holistic package for healthcare with a lymphedema person is extremely important.
Sounds very good. In Norway, since 1991, lymphedema is considered a chronic disease, and the lymphedema patients are guaranteed physical treatment and compression garment free of charge. Do you know the situation in other countries where you have been active, that this exists?
There's huge variation in what patients can get, and it depends on the negotiating skills of the local framework or even local groups. For instance, in Australia, in Victoria, anyone who's in a particular program will get free garments whenever they require them. In Adelaide, in our city, if you go through a particular hospital, you'll get free garments for the lifetime of yourself. And as long as you can establish that the lymphedema or the problem was possibly initiated in that hospital as a consequence of their treatment for cancer. Oh. So what you get depends on where you are and how strong the patient groups and the professional groups are in terms of recognizing the importance of good quality holistic care. And we can keep on coming back to holistic care. That means not just one thing, but the whole package: compression, exercise, activity, etc.
In Sweden, there is only one lymphedema clinic identifying the patient at risk for lymphedema, and only for breast cancer patients. How do you visualize an assessment center for all kinds of lymphedema and lymphatic diseases, or does it exist already?
One of the most important things, I think, is this risk evaluation, risk assessment, and you have to have a baseline. It's without doubt for any form of cancer, not only breast cancer treatment, but also for cancer associated with the bowel or cancer associated with melanomas. If you have a patient who has any risk factor whatever, and this may mean poor skin care, body mass, or a prior family history of the tendency to swell or some cardiovascular problem, then if they have a risk factor, you want to know what that baseline is, so you can react when that baseline changes. And that's the most important thing. That's where we should be going to in terms of proactive healthcare, tackling the problem before it presents, reducing the risk if there's an identified risk. And pre-assessment is the only way in which you can do that.
Mm-hmm. So what is your perception of correct objective measurements of lymphedema? Do you think a tape measurement will do?
The objective measurement of lymphedema is really hard, and in the short term, certainly a tape measure is okay. But in the longer term, if I'm using my tape measure circumferences and the volume calculated from a tape measure, say over 6 months, an arm can get bigger, but it's actually better in terms of the lymphedema, simply because the arm felt better. They do more exercise, they get more muscle. So we have to be very, very careful with tape measures and volume calculations based on tape measures or anything like that, volumetric measures. They have got some problems over the long term because their arm or the leg has got three components, and those components are the muscle, the fluid, and the fatty tissue, basically. And all three of those can change. If my muscle goes up and my fluids go down, that's great. That's wonderful for the patient. But if my fluid goes up and my muscle goes down, I can't tell the difference just by tape measure alone over the long term. So you have to have better objective measurements over the long term. In fact, we're very clear now in terms of the international literature that bioimpedance spectroscopy, that is measuring the real fluid that's in the limb, is probably the best way to go, because fluid is a sign that the lymphatic system has failed. And that's what we're interested in. If there's fluid in the limb right now, that lymphatic system is failing. The earlier we detect that and the smaller volume that we detect, the better the intervention. The more simple the intervention and the better the outcome.
Yeah, of course. In Sweden, the treatment offered in many regions is compression only. Do you consider that an optimal treatment? Do you consider that is an optimal treatment for all different kinds of lymphedema?
Certainly, compression alone, there are some papers in the literature which says compression is good. There's no doubt about it. There's no doubt about compression is great. But alone, it's not achieving the optimum outcome for the patient. Also with compression, one of the big problems is the therapist and certainly the patient sometimes don't think of the issue, what happens when I compress my arm? Where does the fluid go? And this sometimes leads to a problem in the hands or the fingers when the fluid goes down distally. It sometimes pushes the fluid from the limb into the armpit or into the groin. So the fluid has to go somewhere. We know compression reduces the outflow from the vascular system, and that's good. But compression alone is not giving you the optimum outcome. Compression with a little bit of exercise is going to give you a better outcome because that varies the tissue pressure. But compression on its own is rather suboptimal.
Okay. Do you know what evidence level compression has internationally?
Compression has got a fairly reasonable evidence level. There are many groups that are collecting information about it. And the group that's been doing the most work about it, I guess, is Hugo Parch and the International Compression Club. The work of Hugo Parch and his associates on compression is absolutely fantastic. It's very accurate, it's very reliable, and it's dealing with reasonable sample sizes. So yes, there is good quality evidence for compression, but among the good evidence, there's some questionable evidence. So you have to know how to interpret a paper. You have to know about the biases that are in that paper. You have to know about the statistics to be able to interpret whether that outcome is a good outcome or not.
And then what about the evidence level for CDT, combined decongestive therapy and manual lymphatic drainage alone or in combination with other treatment methods?
That's a very good question. Some evidence shows that compression is doing most of the work. Some evidence in some other trials shows that it's the manual lymphatic drainage which is doing the job. This is the problem. We don't have large-size clinical trials in lymphedema. We can't measure outcomes in lymphedema, therefore, all that accurately. There's always a huge range of possible error in the outcomes because of our small sample sizes. So that means we can't always make the strongest statements that we'd like to make about the efficacy of compression versus the efficacy of manual lymphatic drainage versus the efficacy of skin care. So we don't have strong enough evidence. We need more funds to actually give stronger research, better quality research, so we can actually make more certain the statements that we are currently making.
Are you familiar then with new research and evidence-based management methods that may be recommended for common use today? Best practice methods and evidence-based?
Yes. Evidence-based medicine is interesting. I guess we've come from the art of medicine to the science of medicine, and if you can't find out some information about your current treatment, some people will say it shouldn't be used because there's not enough evidence for it. And then what happens, people and groups sit back and do nothing. And if you do nothing, I think that's really bad. You must do something. You have to realise that the strength of the evidence may not be what you're looking for, but there is some evidence there. It's useful evidence, and it may help you guide the patient in terms of the treatment that may be best for them. So evidence is a big problem. In our clinical trials, our randomised controlled trials, for instance, the conditions of entry into those trials are so tight that you quite often don't see the patient that's in front of you in those trials. So you don't know how your patient's going to respond to the treatment on the basis of what you've seen in a randomised controlled trial. So there's some limitations there. And I think every practitioner, every clinician has to make a decision about that evidence. And I'm going to be talking about this tomorrow. Make a decision about the strength of that evidence. Look at that evidence, weigh it up, and then make some decisions as a thinking practitioner. And as well as a thinking practitioner, you have to have a well-educated, knowledgeable patient. So they know when something's working well, they know when it's not, because everyone is an individual. Everyone's lymphatic territories are different, as we're finding out now from the work of Weir and Pan. Everyone's got a different system, and one model doesn't always fit all. I can chat for hours. too much.
In Sweden, many hospital clinics and primary care centers do not provide information from patient support groups. Do you consider it beneficial for the patients and the healthcare system to distribute information from patient groups and associations?
Of course. I mean, if we look at the evolution of the National Lymphedema Network in the United States, and we look at our own patient support groups in Australia, patient support groups can make the biggest difference, because a patient who has got a concern is talking with another patient who's had a similar problem or a similar concern. That patient's experience and their perspective can actually alleviate some of the fears that this questioning person may be having. So I believe strongly in the value of patient information for patients. Of course, it has to be accompanied by professional information and professional decision making, but there's nothing like talking to someone else who's had the problem, who knows what they may be going through, that person with the questions may be going through, and that makes them feel comfortable. There has been some interesting papers recently about lymphedema risk and the fear of developing lymphedema. And in a number of incidences, the fear of developing lymphedema far outweighs the risk of lymphedema. So when the fear of lymphedema outweighs the risk, there's some enormous psychological and social pressures on that patient.
Yes.
In terms of how they interact with their family, their community.
Yeah.
So we have to get the balance right, and this is the really important thing: is making sure that there's information there, making sure the information's right, and making sure the patient's looking at the right information. In other words, on the internet, some information is questionable. And if a patient support group doesn't have accurate information there, they're going to go somewhere else and get that information. And that may not be as good as what a patient support group can offer, who at least has got some professional linkages and a professional commitment to that patient.
Yeah. So a patient support group always needs to find a correct, objective statements and research work to base their knowledge on.
Yes, to base their statements on.
Yeah.
I think having accurate information for everyone is important, but we have to realise that it's not perfect information, but it's better than no information, and it's better than the wrong information if a patient's using that. So we see as a very important role of the patient, and in the International Lymphedema Framework and some other groups, the patient is important. The patient must have information as early as possible, as accurately as possible, from as many people as possible to make the right decision. Because making the right decision can be very difficult sometimes.
Yes.
You need input from everyone, including your family, including your friends, but specifically the patient support group.
Many patients experience and read about new methods for controlling lymphedema. Do you know if some of these methods have enough evidence for common use? For example, laser, lymphopress, circ-A juxtafeed or something similar, deep oscillation, other products that may be new, maybe have some kind of research background or statements internationally, but in Sweden we lack access to it. It's not recognized
It's
treatment.
being strong enough.
No.
Yeah, certainly in Australia we'll have a look at anything that's got a reasonable level of evidence associated with it. And when I say reasonable, we have to acknowledge that there's never the money in lymphedema research like there is for looking at hypertensive medications and the stuff to have really large sample sizes. You'll never be sure that one thing is better than another, but there may be an indication that there's a tendency that one particular type of garment might give you a better outcome than another, or one particular form of laser might be better than another. But the idea and the point that's most important is to make sure we gather as much evidence as there is about these new treatments and apply them, have a go. Treat your patient as a RCT of one, that means a randomized controlled trial of one, and try one different thing at a time. Give it a chance, see how it works. And that's how we've actually got some very good outcomes for our patients, because like I said earlier, everyone is different. You can't find your patient quite often in a randomized controlled trial with all their characteristics of that patient sitting in front of you. They're unique, their lymphatic system's unique, and you have to acknowledge that. In the talks coming up, I'll be talking about innovations. Why are we so reticent to accept some of these innovations? Why do we always stay with the traditional things? And if we look at the traditional treatments, sometimes the evidence is not as good because the science behind those bits of information with the traditional treatments wasn't good in those old days. And the science behind our new innovations, while they have a small sample, the science behind them, the strength of the methods and the methodology is really good. So small sample size, the outcomes, we know they're tending in a particular direction, but they're looking pretty good in some instances. And I use the example of laser treatments, of the circ-A sort of garments where patients can control the garment themselves, and a whole variety of other treatments, stimulating the lymphatics with electrical impulses and the like. We have to give them a chance. If we don't, we're going to be doing one thing now in 20 or 30 or 40 years and not changing, not moving on, not trying to find something that's better than what we've currently got. We have to move on, we have to look at innovations, we have to accept them and then try them and report on them. So other people can then make a decision, should I then start a clinical trial? Some of our best new knowledge has come from individual case studies where a health professional has said, I tried this treatment and it worked well. Someone else has looked at it and said, okay, I'm going to try that in a small pilot trial. And then the pilot trial turns out good and then we move to a full clinical trial.
Sounds gorgeous.
We start small, but you've got to start, you've got to look at innovations, you've got to move on. Like I said, one of our big problems is the strength of the evidence base of old methods and methodologies. It's not always as strong as we thought. It's gone down through the years as being a fait accompli for the best outcome, but it's not always strongly proven.
Now I have a large question. How would you define patient-centered care? It's talked about all over the world. In Sweden, the government has said that the Swedish healthcare system has to develop this patient-centered care. Everything should be on the focus of the patient and the teamwork with the patient. So how would you define patient-centered care?
Patient-centered care is where the therapist has got a good information base about that patient. They've got a good feeling of how that patient's responded to previous treatments and what the patient is thinking about those treatments. Also, those treatments should be focused on what the patient wants. Some of our patients, for instance, don't mind their large limb. What they mind is their range of movement or the tension or the heaviness in the limb. And yet some therapists will go off and try and manage the size of the limb and not dealing with range of movement or the degree of fibrotic induration in the tissues. So the patient's not getting what they want. when they're not getting what they want, they think their treatment's not working and the treatment gets a bad name. So patient-centered care is absolutely important. We must listen more to the patient because it's their issue. It's them we're trying to help. And yet most often we end up trying to help ourselves by persisting with something that we think is going to be beneficial for them without involving them, without involving their family, or considering the environment that they're living in. And I guess if we look at countries like India, where optimum care is not possible, but good quality care is possible. We don't have the ability, as the work of Terence Ryan shows us, we don't have the ability to have full compression garments, the ideal compression garment. But in India, you can have cotton bandages. You can create pressure with cotton bandages. You can create a barrier for wounds with honey. And those sort of things. You can do simple things. And sometimes those simple things are working as good as the more complicated processes and strategies.
Sounds very good. So, what future positive developments do you see in the near future? I know that the International Society of Lymphology has a congress in Rome. You're going there. What do you see as new fantastic hope for lymphedema patients?
The new hope, I guess, is that if we can detect lymphatic problems earlier on, we can intervene early, number one. If you want to take a direct surgical option straight away, for instance, lympholymphatic anastomosis or super microsurgery, you can make that decision early on, before the lymphatic system starts failing, before fibrous tissue develops. And the work of Pichardo and Campisi and Kashima and those people say, I wish we'd have these patients early on, because if we had them earlier on, we can get a better result, because the tissues haven't changed. Then we look at other options like liposuction. Well, liposuction, you can't do much with fluid. You have to wait until it's fatty tissue to get the best outcome. And this brings us back to the picture of knowing what's going on in that limb. What's the composition like? What's the fluid? Where is it? Which lymphatic territory is involved? Where's the fatty deposits? Where's the fibrous deposits? And what can we do to actually work out the optimum sequencing, the optimum treatment for that patient? Where they're living, with their resources, with their health insurance, what can we do that's optimum for them? We have to involve them in these decisions, and we have to ensure that we're giving them feedback about what we're doing, why we're doing it, so they can maybe keep a reflective diary on how things are going and then feed it back to the health professional. Lymphedema, like I said earlier, non-life-threatening, it's chronic, it's a damn nuisance, but it's a partnership through the rest of that life of that person between the health professional, their clinicians and the family to actually ensure that that lymphedema is well managed and well dealt with, and that we listen to the patient.
Thank you for that. I just wonder, you said that lymphedema is not life-threatening, but it does have one complication. It may occur one complication, and that is cellulitis.
Yes.
Do you have any thoughts, recommendations for that? How can you reduce cellulitis for the lymphedema patients if they are treated regularly, and if they have patient information and skin care and all this? Will that help them not to develop cellulitis?
Certainly, there are two things which can help reduce the risk of cellulitis. Number one is looking at the lymphatic system's functional status. If we can make the lymphatic system work a little bit better, flow a little bit quicker, then the defense mechanisms can react quicker to bacteria. So that's the first thing. The second thing, I think, is stopping the bacteria from getting into the tissues in the first place. So that means the skin as a barrier, as a mechanical barrier. That's what I was talking about earlier about honey. It's really, really important to have a barrier. It doesn't matter what it is, as long as it acts as a barrier, stops the bacterium from getting in. If they are in there, well, you're looking at a different ballpark. You're looking at different treatments and managements. But the faster we can get the lymphatic system working, the more likely it is to actually be able to manage that bacterial onslaught itself. So speeding up lymph flow, encouraging white blood cells to do their job in the tissues, is a good strategy. And what we had to do is come back to what's going on in the future. We missed some of the most important points of what's around the corner for our patients. And there's a couple of really important things. The first one, apart from the fact that we need to detect the lymphedema earlier on so we can actually work out what pathway is best for that person, whether it's surgery straight away, anastomotic surgery, or whether it's conservative therapy, or whether it's skincare or exercise or activity or weight management. But one of the more important things is the work that's being done by groups such as Stanton and Peter Mortimer and the crew, who are actually now realizing and discovering that those people who get lymphedema have got something wrong with their lymphatic system. In other words, there's a genetic predisposition to a whole lot of problems. And it may be that genetics is influencing the outcomes, the risk of lymphedema, perhaps more so than lots of other things, because of their suggestions, their work that they're doing. For instance, lymph flow is higher in people who get lymphedema. Lymph pressures are different in those people who get lymphedema. The margin between the load and the maximum transport is less. So it doesn't take much to tip them over the balance. And their work can explain the surprises that sometimes happen. That there's a minimum intervention and the person's arm or leg swells up. It's a surprise. And in some cases you can see that that's hypoplasia, not enough lymphatic vessels, but in others it's their lymphatic system which looks normal, but it's not functioning normally. So one of the things may be looking at the genetic basis of all these people who are perceived to be at any risk whatsoever before. So we can predict the risk and identify it and then interact and act early to stop it from developing into clinically manifest lymphedema. And as I said earlier, one of the most important things is looking at the fluid in the tissues. The fluid is the first sign of lymphatic failure. And we can do that now with bioimpedance spectroscopy. We can do it with dielectric constants, such as the group in Finland. We use that quite often, looking at fluids at various depths in the tissue, various lymphatic territories. And you can get a feeling of how their lymphatic system's working. So this is one of the most important things. The other thing, I guess, everyone's favourite is the stem cell work around the world, where we're looking at trying to grow, not us personally, but others are looking to try and grow lymphatics and lymph nodes. And sometimes in some lymphedemas, it appears that lymph nodes do grow spontaneously after the lymphedema is developed. But maybe they missed out on these nodes in the first place. We're not quite sure about it. But looking at genetics and looking at cell growth and the creation of new lymphatic nodes and collectors from stem cell lines looks like an interesting way to go. Is it good for everyone? It's pretty tough and it's going to be pretty expensive. Yeah. So one of our key things, I guess, is going right back to square one. And that is the surgeons, the radiation and medical oncologists, and saying, okay, we've got to take more care of the lymphatics when we're intervening. Okay, we've got to protect the lymphatics a lot more. We're saying to the patients, well, you've got to tell us when things are changing. We've got to say to the therapists, well, you need to do a measurement before they go into surgery, before they have radiotherapy, so we've got a baseline. And then we can react and act earlier and get better outcomes with a much simpler treatment program. And in the simple treatment program, the patient can be involved right from square one and maybe stop their swelling from ever developing into clinically manifest lymphedema.
But when you do that, you said you go back to square one. In Sweden, the lymphatic system and lymphatic diseases is not very well described in the courses to become a doctor, nurse, physiotherapist. It may be 1 page, 2 pages, so forth. Would you have a recommendation, or have you managed to change internationally the course plan so that everybody becoming a registered medical professional knows what the lymphatic system is?
It's always hard because there's so much to learn in the medical course, and not every GP or family practitioner can be an expert in everything. But what we've got an opportunity to do is to allow a certain proportion of those specialists, the GPs, to come through with enhanced knowledge. For instance, in our medical school, every year now I'm getting about 25 out of 130 students coming in doing a 6-month specialist elective. And these people, when they go out, are going to be knowledgeable. They may become focal points for lymphatic treatment, lymphatic management, lymphatic assessment, lymphedema assessment. So things are changing, but slowly. The International Lymphedema Framework has recently commissioned a report on educational requirements, what has to be in a curriculum in order for us to be confident about what's needed in terms of the knowledge of health professionals. And part of that's the understanding of the basic anatomy, part of it's pathophysiology, part of it's treatment knowledge, part of it's assessment knowledge. So there are lots of courses, there are lots of recommendations around, but we don't always use them. And that's always the sad thing. There are many international bodies, the ICC, the Leg Club, the International Union of Phlebology, the International Society of Lymphology, local groups, the Dutch Lymphedema Framework Group, the Italian groups. They spend a lot of work, and a lot of experts spend a lot of time on these consensus and best practice documents, as do we at the ILF. And people don't tend to use them like we should be using them. You don't have to use the whole document, but there may be parts that can actually make a difference to the local lymphedema group in terms of knowledge acquisition and teaching of the therapists. And if we look around the world, we find that there are various international groups like the Dr. Voda group, the Foldy group, the Leduc group, who teach therapists, who teach massage therapists, who teach physiotherapists, and formally give them a qualification once they've gone through their course. And so you can be confident that they've got a reasonable knowledge base. But what we have to make sure, though, is that knowledge base is updated. So there has to be a recertification or a check on them, as they do in the Dr. Voda group, every couple of years to make sure, hey, you know the new stuff and you know what you're doing. And I think then you can expect to get the best outcomes. But there's a lot around, there's a lot of international work done, best practice, templates for practice, guidelines for practice, information we need to get good outcomes, but very little of it's unfortunately used at the moment.
So, Professor Piller, you've spent months in Sweden years ago, and you keep coming back to congresses and conferences, and you're a great patron of the patient support group in Sweden. What are your recommendations for the future? What are your thoughts about the development in Sweden as you see within lymphedema and lymphatic diseases?
I think we've got enormous potential. We all have, every patient group, every practitioner group starts somewhere with someone's enthusiasm, and I can see there's great enthusiasm here in Sweden for it. We just need to work on what can give you the best outcome from the point of view of getting the optimum amount of financing to make sure it works. There's nothing worse than a half-baked proposal or a half-baked outcome. That means something that's not done properly when you have the opportunity to do it properly. So funding is important. Enthusiasm I can see is here. Commitment I can see is here. And I can see that there's a strong need from the patient point of view to have some information available to them about what can be done. At the moment, I think some of that is lacking in clarity. Some of it is lacking from the point of view of different beliefs and different groups pulling in different directions. Lymphedema is a holistic problem. It's a problem not only of the size of the limb, how it feels, its impact on the patient's ability to work, the person's social interactions and stuff. And likewise, the health professionals and the others who manage them also have to be dealing holistically, communicating together, working and moving on together.
Thank you very much, Professor Piller.
That's all right. Thank you.
Thank you.